All right. Thanks so much, Dr. Khan. Welcome, everybody. I know it's depending where you are later at night after work. For those of you on the East Coast, I know it's even later, but thank you for taking the time to be here for tonight's webinar. As you all know, the topic is mastering surgical extractions. Now, of course, this is a course that has a significant amount of detail, something that we can do even over a 2 or 3 day weekend. But what I really wanted to try and do in this short amount of time we have together is to provide as many highlights and key takeaways that everybody will be able to implement immediately starting tomorrow with your first extraction case moving forward. So, as mentioned, feel free to post whatever questions you might have. As soon as we get through our hour presentation, I'll stick around to answer any of those that you might have. So, to
Uh,
respect all of your time, we'll get going for you right now.
Dr. Shamarty, I think there was a
Yes.
question from Dr. Rosenthal.
Oh,
Dr. Rosenthal? He was raising his hand.
I don't see it on
Okay.
my.
So, all right. Okay. So probably it's okay. All right, carry on.
Okay, I didn't see it on my end. So, all right. So, yeah, with that being started, of course, we wanted to thank our sponsors again, A Southern, and of course, Catapult Education. And just for background, to get into this topic, again, we know that we extract literally millions of teeth every year. And why this topic has started to gain a lot more interest and popularity is because we're all starting to do a lot more grafting procedures. This has now increased at a rate of over 13% a year and growing. So we know this is something we're going to be dealing with quite significantly, and we want to just be able to be more efficient and better at what we do. And the reason why we worry so much when we talk about extractions is that, as we all know, once you remove a tooth, there are going to be major functional and aesthetic changes to the site. Now, in the aesthetic area, of course, that raises the game that much more, compromises those sites even more. But regardless, in the mouth, anytime you remove a tooth, you're going to get big time functional and aesthetic changes. You are always going to get some degree of bone loss. So, what we really want to do is learn how to improve our technique and master our technique to the point where we can minimize the amount of these functional and aesthetic outcomes as best as we possibly can. Now, this doesn't matter again whether we're in the anterior, whether it's multiple teeth, a posterior or extension, or even a full arch. How we go about our technique will make a significant impact on what our final outcomes are going to be. So we always want to find the ways to do things in the most efficient manner possible. And it can be as straightforward as cases that seem easy, but actually end up being a much bigger challenge than we thought going in. We'll look at a case like this and we'll see there's a fracture, there's some mobility on the tooth radiographically. We'll think, well, I don't really see any lucency there. This should be a quote unquote easy extraction, always a fatal last word, famous last words to say. And then, of course, we start seeing things are a little bit different. We see a little bit of puffiness, swelling in that tissue. And sure enough, by the time we extract these teeth and we start learning about how we're going to raise flaps more efficiently and extracting and cleaning out all the infection, we start seeing we've got significant impacts there on the bone. We've got significant bone defects, which we're going to specify in just a moment. And we start seeing that these cases are a lot more complex than maybe we bargained for. So, unless we have a very systematic approach for each and every one of our extraction cases, we want to make things as efficient and predictable as possible. So, it's all about our technique, our instrumentation, and our preparation, not just for ourselves, but just as importantly for our teams. We want to make sure that our staff and our dental assistants know when we have an extraction case exactly what instrumentation we're going to have, exactly what type of regenerative materials that we want to use, and we want to make sure that our front desk know how to plan us for success in terms of how much time to schedule as well. So, straightforward case, we have to start asking ourselves, how do we do flap management? How do we go into understanding which specific type of bone graft or membrane material we're going to use? Obviously, this is not a in-depth seminar in regenerative materials. We will touch on that, but suffice it to say, things like that, along with our flap management, our suturing technique, and our suturing materials, all make a big impact each and every one of these steps is going to impact what our final result is going to be. And what we hope is that once we do these cases, we can get to a point where we can have these sites that we've got really good healing, really good three-dimensional bone, and whether we're going to be doing implants in the future or bridges or whatever it is that we're going to end up doing, we have cases that we're really confident that we can regenerate like this on a consistent basis. So everything is about our technique and really bringing a very systematic approach to each and every one of our cases. So our goal is to get in situations and be so confident that having significant infections and bone defects like we're seeing, we can very confidently know that we're going to be able to treat these in a way that we can get this type of solid bone at the end of the case. As we're all aware, these cases are not easy. Anybody that thinks extraction cases are easy are obviously mistaken. That term, simple extraction, to me always makes me laugh. I always think if those cases were so simple, they wouldn't be referred to us in the first place, right? So as we're all aware, these cases are very stressful. There's a big time component. And of course, if we're not prepared, if we aren't very systematic in our approach and we don't do things in as efficient of a way as possible, now we're worried about running behind. And of course, there's a big fear factor. If we're not familiar with these cases, if we don't have experience and we're not prepared, well, then we can become very hesitant in terms of how we're going to treat these cases. It'll lead to a lack of confidence, which then makes us more fearful of taking on the next case. So the goal is by the end of this short amount of time that we have, everybody will have a better systemized approach, which will give you much more confidence and help you approach these cases with a lot more better understanding. So, quick background, I've been practicing as a clinical periodontist, board certified now for over 16 years. I've been in the academic world teaching at both Harvard and UPenn for the entire period of time. I serve as the medical director of regeneration for Nobel Biocare and fortunate enough to be again member of the Catapult Education Bureau, which all this is really to say that when it comes to not only doing these cases and executing them clinically, but also having to teach these courses in an academic setting, I'm very familiar with all of these processes and what our pain points are. And my goal today is to, in our short time, give each and every one of you a couple of essential tips that you'll be able to move forward with. So one of these tips that we're going to learn in our course today, first is going to be to go over some of the top mistakes our colleagues make when approaching these surgical extractions. Some of them may sound more simpler than others, but again, it's all about consistency and it's all about creating these types of systems that we're going to be able to do for each and every case. So everybody will be able to have a modern, predictable, step-by-step clinical approach by the end. And then in order to bring all of this together, it's a question of how do we build these foundational pieces into lifelong surgical confidence, right? It's all about repetition and it's all about reinforcement. So at the very end, I'm going to show everybody and invite everybody into a community that will allow you to build on this surgical confidence that you're going to get in a community aspect to help you execute these cases and reinforce these lessons over time. So, let's say we've got a repeat there. And you'll get that bonus, and I'm going to be providing everybody a free bonus surgical instrument checklist because as we go through our course today, a lot of people ask, what are some of the tools that you use? What are the names? What are the companies? So I will be providing everybody this at the end of our hour today. So stay tuned for that coming up. So with that being said, now having an understanding of what we're going to do, let's jump right in. And tip number one, in order to have really good success with your mastering surgical cases, you have to plan ahead to minimize surprises. Again, sounds easy, but we don't always do that. So what do we mean by plan ahead? Well, all of our surgical extraction cases that we're going to be treating are essentially going to fall into two different categories. There's going to be one set of cases that we're going to be doing where we are dealing with extraction sockets that do not have any bony wall defects. Now, again, we're going to define a bony wall defect in just a second, but suffice it to say, the way we treat a extraction socket when we've removed the tooth and have 360 degrees of solid bone all around that socket, how we go about treating those cases is going to be different than how we go about treating cases that do in fact have bony wall defects. So In terms of planning ahead, understanding whether or not we have that bony wall defect in place is going to make a big difference. And one of the major ways that we're going to be able to do that is going to be through 3D technology, which we're going to highlight in just a moment. But you also need to understand for your foundational aspect what a bony wall defect is. And there are two specific types that exist. One is known as a fenestration, and one is known as a dehiscence. As you can see, in 20%, one out of every five of our cortical plates, we naturally have these bone defects to begin with. But now, if you start throwing in factors like infection, like fistulas, like things like trauma, the amount of these bony wall defects, the percentage of those increases significantly. And again, we have to be able to identify these when we remove these teeth in order to then know how we're going to attack these cases. So, to help differentiate both for you in terms of the nomenclature, a fenestration, which as you can see according to the classic literature is usually found more often in the maxilla. What we mean by fenestration is a small window of bone that is missing. So as you can see on that tooth, that bone area that's circled for you in the diagram, you can have an entire area of that buccal plate that's nice and intact, but there can be a small portion, whether it's in the crestal third, the middle third, or the apical third, where you have a small window of bone that's missing, and that is what is known as a fenestration. We differentiate that with a dehiscence as being a entire area of that bone that's missing. So when you look at that lower mandibular tooth there, you can see that that majority of that buccal plate is missing altogether, and that is something that is known as a dehiscence. Part of what is so tricky in identifying these is that they're not always going to be found in the same area. Like we mentioned, it might be at the apical third, it might be at the middle, or it might be half the tooth, but not the other half. So it's really important that clinically you're able to identify from the base of the socket all the way up to the crest on both buccal and lingual or palatal side to identify whether or not a bone defect is there. Because a lot of times we'll feel the crestal bone and we'll think, okay, this bone is fully intact, whereas apically there may be a huge defect, similar to that case I just showed you at the beginning. So very important to identify whether or not that bony defect is there. And as mentioned, outside of doing it clinically, once that tooth is out, in order to plan ahead, 3D technology really helps us do a lot of this work before we even touch that patient. So when we look at some of our CT scans, for example, this image on the left here with that premolar, we know before we've even started the case that there is no buccal plate there. We can see that there's a dehiscence there of about, the top half or 2/3 of that buccal plate. So from a treatment planning standpoint, this is golden information because now when we treatment plan that case, we're going to be prepared in terms of graft material, in terms of membrane material. And this is very important because a lot of times what ends up happening is that we look at a 2D PA, like that first case I showed you with the fracture, where things maybe on the PA looked fine. And we think, okay, well, we're just going to be doing a bone graft. We might not be doing any membrane work. Of course, you remove the tooth, you end up seeing that the infection and the bone defect is significantly bigger than what you had anticipated, and you may not have the material. And even if you do, you now have that uncomfortable situation where you have to have a conversation with your patient as to why you're charging them for additional material that they didn't have in the first place. So, all these things can be avoided by having that radiographic data on the front end. We can see PA lucencies, furcation involvement, and you can see the quality of these CT images if we're going to be dealing with that maxillary anterior tooth. The aesthetic zone is the area that we're most concerned with aesthetics and function. It's the area where our buccal bone is thinnest in the mouth. So you can imagine having a good idea going into the case of whether or not we have enough of a buccal plate, where the anatomy is for that canal on that palatal side. All this information is gold to us. So, in order to be planning ahead, we have to be able to be prepared by having that radiographic information on the front end. Another quick example of the same thing, 2D PA. I know there's a little bit of a lucency there. It looked like this might have just been some kind of a lateral cyst by the time we flapped the area and I had to start curetting. This was a defect that was much bigger clinically than it was radiographically, and it went from the buccal side all the way through and through to that lingual plate. This was a much more significant regeneration type of defect procedure than what it looked like. So again, the more information that we can get, the better we can plan ahead, the better we have our materials on hand, and the better we can prepare our patients as well. The other part from a preparation standpoint is understanding biology. And while, of course, in our limited time, we can't go through every detail on this slide, suffice it to say, the better that you understand the overall wound healing process, this has not changed. They've revisited these studies, as you can see, over 60 years, and the data simply shows to the same sequence of how sockets heal. So part of my conversation with each and every one of my patients on their post-op, for example, is always to educate them that it takes approximately 6 weeks for epithelial coverage to occur. By epithelial coverage, we're talking about that soft tissue forming all the way up and over that socket and creating that seal. That's a very small detail, but a very important one because I'm sure all of you on this call have had patients call you after extractions 2 weeks, 3 weeks in, thinking that they still have complications or maybe infections because they say, I can still feel a crater there. I still feel like food gets stuck there. Something is wrong, when in fact, there's nothing wrong at all. It simply takes the biology 6 weeks of time for that soft tissue to close. So that is one of many important lessons we get from this slide. And the bottom line is understanding that biology and giving your patient this information again on the front end, being prepared, knowing how big your infection is and approximately how long you're going to need to allow that socket to heal before you ever consider re-entering that case. All of that information, knowing that on the front end is again critical to setting yourself up for long-term success and better patient outcomes. The histology is very clear. We know it takes about 2 weeks to start getting hard tissue formation, about a month for it to start forming over the wall of the socket. As we said, 6 weeks for epithelial coverage. And it is no sooner than 12 weeks, excuse me, that we get a socket that we can consider even being mature. So oftentimes when we are asked, why do we have to wait so long for these sites before, for example, we consider implant placement? Why are we waiting so many months? I tell my patients all the time, if you fracture or break your wrist, your doctor puts you in a cast. The reason they put you in a cast for as long as they do is because the biology dictates how long it's going to take for that bone to heal. It's no different within that extraction socket. The reason we have to wait 3, 4, or up to 6 months, depending on the case, is simply based on the extent of the defect and the biology of how long this regeneration takes. So understanding this process very well is going to set you up clinically for success, but is also going to help you educate your patient and manage their expectations, which we know is very important because they're going to be having the experience and ultimately they're the ones that we're trying to treat. So again, tip number one, know things going in, understand the biology, and have a really good radiographic analysis to set you up. Of course, when we talk about mastering this overall technique, we have to understand what we can do to make things systematized and have a really good, efficient system for all of our surgical extraction cases. And of course, technique matters a lot. So we talk about techniques that we'll touch on briefly here, known as sectioning. There are regenerative procedures that we talk about in future hands-on courses like the ice cream cone technique. We talk about grafting with membranes and plugs. And of course, that's not even getting into soft tissue and flap management. So many things we can go on, but for tonight, we're focusing specifically on how we can master extracting these teeth in as efficient of a way as possible. And in order to do that, we have to have the right armamentarium. So anytime we talk about minimally traumatic or atraumatic tooth extraction, there are very specific tools and instruments that help us do our job consistently and systematically. The first is we always want to utilize high-speed handpieces, preferably electric. The reason we aim for electric handpieces is because they offer us the most amount of torque. And by having the most amount of torque, for those of us that are having to cut through crown and or bridges when we do the extraction, not only do we want to minimize the chair time, we want to create the least amount of fatigue on our muscles as we're doing these extractions consistently day in and day out, and we want to be efficient. So utilizing an electric handpiece is going to help us because of that added torque. It's going to help us be far more efficient. In addition to that, when you have burrs that you're going to be using, we want to emphasize that those burrs, when possible, are always going to need to be surgical length. We're going to be dealing with teeth that are broken and that are decayed and that are really deep up and below that osseous crest. It's critical that we have surgical length burrs. Then we get into our specific instruments. There are a couple tools that are game changers for us when it comes to extracting teeth atraumatically. Specifically, my go-tos are instruments known as periotomes and as exotomes, and we're going to highlight each of them in just a moment so you'll understand how we make use of them. That being said, last but not least, that does not mean that we never utilize traditional elevators and forceps. What it does mean, though, is that we're going to allow the handpiece, the periotomes, and the exotomes do 90 to 95% of the work so that when we get to the point where we even consider using our forcep, that the majority, if not all of that luxation has been done, and that forcep in many cases won't even be necessary, or if it is, it's really the finishing touch. It's all about avoiding putting excessive force. And when we use traditional elevators, which have much bigger beaks to them and are much more aggressive, and forceps putting that type of traditional buccal lingual movement, we are putting excessive amount of force exactly on the area that we are most trying to protect. Our buccal bone is our gold, so anything that we can do to avoid putting excess force in that area is a win. And this is why for all of our teeth, any of these teeth that are multi-rooted, anytime you see a furcation involvement, multi-rooted molars, premolars, we are always going to section each and every single tooth into its smaller individual roots. Even when we think of longer single-rooted teeth like canines or even centrals, when they are severely decayed, when they're broken below that gingival margin, which happens all too often, whether through trauma, a post-breaking off, etc., you have nothing to grab onto. So trying to use a traditional elevator, as you know, those very prominent buccal tilted roots on a maxillary canine, you're going to lose that buccal plate. So even in those situations, we are sectioning these teeth. We're creating smaller individual sections to be able to remove. And again, in utilizing our periotomes and exotomes, we're going to be able to atraumatically remove each of these individual parts without putting that force on that buccal plate, which is so critical. And last but not least, once we've sectioned these teeth, for those instances where we are going to then, once we've done the majority of the work, grab them with our forceps, what we're going to understand is that we're going to change the way we create our motion. What we were taught when we were in school was always not only to put apical pressure, but the heavy bulk, 2/3 of our force was always told to go towards the buccal and then to the lingual side. Well, again, when our buccal plate is our most delicate area, our thinnest area, and the area that results in the most functional and aesthetic changes, why on earth am I going to put the most amount of my force in the area that I am trying to protect? So for that reason, we're going to be able to section these teeth and then employ a rotational movement similar to what we would do on conical roots so that we can avoid putting pressure on that buccal plate and extract those teeth again in as atraumatic a manner as possible. So we'll go through each of these steps real quick. As mentioned, when we want to section our teeth, we're going to utilize an electric handpiece to have the highest amount of watts available to us, the most amount of torque. And as far as burrs are concerned, anytime we're having to cut through very aggressive metal or crown structure, we're going to utilize an aggressive diamond to cut through that crown structure. Of course, if you have a crown remover that you can get in and underneath, great. But if you don't, you will use an aggressive diamond. But when we're working on natural tooth structure, we're going to focus on surgical length carbide burrs. It could be a carbide burr like you're seeing pictured there. It could be a surgical length 557. There are a lot of different options that are there, but the key is that we are going to section these teeth. And like we said, we're going to focus on the electric because it just gives us way more torque, usually 3 to 4x the amount of torque that we're going to get with any air-driven handpiece that we're going to find available there. So how are we going to section these teeth? We're going to focus for the most obvious examples, the ones that you're going to be dealing with the most, which are the molars. For a mandibular molar, which has two specific roots, a mesial and a distal, we're going to section that tooth right down the middle into its mesial and its distal root. So rather than having one solid large tooth that we're having to try and extract and grab onto, again, keep in mind what's getting referred our way is severely decayed, they're endo-treated and brittle. We're not going to have the luxury of a nice, intact, healthy whole tooth to grab onto. That's a blessing that's extremely rare, if ever, that happens. So we're going to section these teeth into its individual, smaller, single-rooted teeth sections. And we're going to get each one of those out individually. The same is true for the maxillary molar. So if we picture that area towards the north as being the buccal, the easiest way to think about how we're going to section these maxillary molars is thinking of the Mercedes-Benz symbol, where we're going to start directly in the midline at that buccal area. We're going to travel right down with our burr until we roughly reach that middle part of the tooth. We're going to then flare to the mesial and flare to the distal. And by creating that Mercedes-Benz symbol, we're going to separate that molar into its mesial buccal, distal buccal, and palatal root. And now we've got three individual sections that we can focus on with our next set of instruments to get out. And we have a purchase point that we've created in the area that we have created the sectioning, which is taking our force when we go to elevate away from that buccal plate that, again, we are working so hard to try and preserve. So as mentioned, whether it's crown, natural tooth structure, or a crown material, we're going to use our burrs to create that sectioning. Here again, you can see what that maxillary molar looks like with our Mercedes-Benz symbol, where now we've got three individual parts that we can atraumatically go after one at a time rather than one big bulky area that's going to be decayed, that's going to be brittle, and that's going to force us to put the majority of our force on that buccal area. And that's what we're trying to avoid. So how do we start accomplishing this? Well, like I said, our first instrument that we're going to use that's going to help us do this is known as a periotome. Now, we're all aware that our natural teeth have a ligament around it, the PDL that's there. Now, this periotome instrument is very thin, it's very skinny, it looks like a long, skinny beak. And the way it works with the exact same motion as we would be using our traditional elevators, this periotome is going to be able to work right into that PDL space. And by doing so, it is going to separate that tooth from that ligament space. And by doing so, it's going to now create for us a nice little purchase point area to which we can then go to our next step and employ our exotomes. Now, one trick for those of you, once you start using a periotome, a common question is, how do I know when I'm using the periotome if I'm in that PDL space or not? The way you're going to know in the mouth is that you're going to feel it going down into that space. And anytime you're not sure, if you let go of your instrument, that periotome is going to be stuck right into that PDL space, whether you're on the maxilla or the mandible. So you'll know if you're in that PDL by that instrument just staying right there in position. So that's a good trick to know if you're in that position. Now, as mentioned, once we've created that purchase point, because we've separated that PDL, we can now come in with our specialized instruments known as exotomes. And exotomes are just a fancy word for very targeted elevators. And what these elevators are, they come in all different shapes and sizes and angles, and they are very long beaked and narrower. So if we think about a traditional elevator, it is obviously much thicker and much more aggressive, and as a result, results in putting a lot more force on the bone. So what these exotomes are able to do, depending on what root we're working on, for example, the palatal root on the maxillary molar, the distal buccal root on the mandibular molar, we're going to be able to get periotomes that are made to specifically angle and fit into these spaces. We again use the exact same motion as we would a traditional elevator, but it will allow us to get down further along the length of the root and be able to put a lot less force on that bone while still extracting these teeth. Now, not in every single situation is it going to be as simple as this, but a case like this is going to actually be more common for you than you think. This is an exotome that's targeted for that mesial root, and you can see the way it's long beaked and angled, and I can literally go in there after I've used my periotome and do that exact motion and extract that root. Now, I'm definitely not going to say that every one of your extractions is going to take that fast. I don't have time to show a 5 minute or 10 minute extraction case, but you're going to be surprised using these techniques, sectioning the teeth, going with your periotomes and then the exotomes, how many times that you're actually going to be able to remove these roots as fast as that actually is. And as mentioned, our goal with our exotome, if we can remove the whole root, great. But our real goal is to get that root so mobile and so luxated that then using our forceps is really just a finishing touch at that point. And as mentioned, what we're going to be doing with our forceps is rather than going the traditional majority of the force on the buccal and putting all that pressure on the same area of bone we're most wanting to preserve, now that we've got section teeth that are individual rooted, we're going to employ, just as we would on a traditional maxillary central incisor, a rotational movement to be able to extract those teeth. So a quick example here on a tooth that had already had the periotome and the exotome work done. I'll show this video again in a little bit, but what you can see with our forceps is that once the bulk of the work has been done with the exotome, that tooth is already nice and mobile. So once we employ our rotational movement, that tooth is going to be able to be removed with significant amount of less force, less energy, and more time efficient. So that is a real consistent way with all of our teeth where we can section them, use our periotomes, use our exotomes, and if needed, use our forceps. Now, again, as mentioned, the reason why, and I want to remind everybody why we're using these specialized instruments is because, as I said, the teeth coming our way are never going to be nice and healthy and intact. They're going to be severely decayed. They're going to be endo treated. They possibly had multiple endos. They're going to be very brittle. They're going to be broken at, if not below, the gingival margin and the osseous crest. You can see on that central, right in the aesthetic zone, you've got a big fenestration there. So how are we going to go in with a traditional elevator and forceps and not risk that very, very thin but golden delicate buccal plate, not removing that if we're not using these very fine and targeted instruments? Because what we're trying to avoid at the end of the day is a situation like this where you got the tooth out, but you also got a heck of a lot of the bone out with it as well. And that's what we're trying to avoid. So our goal at the end of the day by using these techniques is to try and keep our sockets as intact as absolutely possible. Now, the reality is that although we can achieve this, a lot of the times this is not possible in each and every case. It would be naive to think that's possible. There are going to be situations where you've got teeth, again, that are endo-treated, that are extremely brittle. If they have very narrow roots and very thick bone, you're going to have the situation where every time you try and touch that root, it's going to keep chipping and breaking down to you. You're going to have teeth that have such severe curvatures to them at the apical that they have undercuts and are stuck in there. So we're going to have situations where we're going to have to do something known as troughing, which basically means we're going to have to remove a little bit of bone around the border of that root to provide more space to us to be able to extract those teeth. Now, it's really important to note, even if you have to do this, it's okay, because if you stay within the confines and the border of the root itself, you can still keep the 360-degree area of that buccal and that lingual palatal plate completely intact and only be working on the internal area of that socket. So even if you have to remove a little bit of bone from that area, that's okay. That's all stuff that you're going to be able to come back and regenerate once that root is out and you do your grafting procedures. So there are going to be situations, curved roots, undercuts, very narrow roots and thick bone, where you may have to do this, but that is totally fine. You can't avoid it every single time. But what is very important is that even in the situations where you do have to do a little bit of troughing, just a small amount of bone removal will then allow you to go right back again to your original steps, use your periotomes and then your exotomes, and that is where those instruments are really going to shine, because you're going to see them literally fit within these sockets like a shoehorn would and wrap themselves around the root. And again, you're going to be able to extract those roots far easier and less traumatically than you would with our traditional techniques. So once we've removed it, mission accomplished, right? Well, not necessarily, because what the biggest mistake I see being done with extraction cases is that once our teeth are removed, we think mission accomplished. We might little scurry around with a curette for a few seconds and off we go. But I will say this is the most overlooked and to our peril part of the surgical extraction procedure. Both of these cases that you see on the screen were cases referred to me for implant placement, where our 2D radiographs highlighted the peak of bone. It looked like that bone was totally intact. But once we flapped the area, there was nothing but soft tissue within that socket. By the time we curetted out that soft tissue, it looked like that tooth had been just removed all over again from the very start. In fact, that green circle, you can see that darker red circle within that socket. That is a maxillary sinus access and perforation that's there. The take home to this is that anytime you remove a tooth, I have a rule called the 80-20 and 80-20-80 principle, where however long it took for me to extract that tooth, I'm usually spending 2 to 3 times the amount of time cleaning out that socket. You will be amazed at the amount of granulation tissue that's present, and you're going to be amazed at how the radiographs absolutely do not match what you find clinically. Clinically, things are always worse. I will highlight with you in our free surgical instrument list the best curettes on the market that are serrated and will help you remove this tissue in the most efficient way manner. But what I will tell you, one big take-home trick is that anytime you've curetted your socket and you think you might be done, everybody, if you can see this, I'm going to pretend this is a gauze. I'm going to get my gauze. I'm going to open it up. I'm going to put the tip of that gauze within the socket. I'm going to use my curette to put pressure and pack it in. I'm going to wait for about 5 or 10 seconds. I'm then going to remove that gauze. I'm going to look in with my loops, and I will guarantee you guys 90+% of the time, you are going to find more granulation tissue. And if you leave infection tissue there, your ability for the socket to heal properly, for the clotting to occur, and if you're grafting the area to get good regeneration at the end is going to be completely compromised. So that is something that you're going to find makes a huge difference. So greatly overlooked, but again, to our peril. So make sure you spend the time to clean the socket. And as I mentioned, people will look at a radiograph like this and say, oh, there's just a small periapical radiolucency. And it's like, my rear it is, because once you get this out, clinically things are much bigger. And the goal is by the time you finish curetting everything, you should be able to look into that socket, not see that granulation tissue anymore, and see that things are nice and intact. So that's our goal. Clinically, things are always going to be bigger. Now, as mentioned in our course tonight, our goal is to give you this step-by-step systematic approach on how to remove the teeth. But as we all know, the overall process of ridge preservation is much more evolved and involved, I should say. There's a whole 3-hour lecture on just regenerative materials themselves. There are multiple different type of bone graft families that are out there, known as the autograft, allografts, alloplasts, and xenografts. There's an entire lingo and language to that comes into play. What I can tell you as take home, as far as a kind of like a Swiss Army knife product that will work for all of these types of cases, our good friends at Osteogenics has a bone material that is 50% cortical, 50% cancellous, known as Encore. Why this is a great type of bone graft material for the majority of the cases that you do. With cortical and cancellous, you get the best of both worlds. With cortical bone, it provides us very good space maintenance. We think of rigidity within that bone. It will help keep those walls from collapsing and give us a nice solid space maintenance for the few months that it needs to heal. But employing good cancellous bone within there is important as well, because we need porosity and spaces within that socket to allow good blood flow and turnover of that material. So having this mix gives us the best of both worlds. So this is one very good example of a graft material that you can use. But like I said, there is an entire other language with regenerative procedures, depending on the case, depending on the time of reentry and what's going on. So these are things that we can, in future courses, talk about in full detail. But I wanted to show you one example of that. The same can be said, and I would say is even worse and more involved when we talk about membranes, because membranes have their own language as well. There are two different types of membranes. There are membranes that resorb on their own. There are membranes that are non-resorbable. They have completely different characteristics. They have completely different indications, risks, and times when they're of good use. And it gets more complicated because, as you can see, in the resorbable category, there is such a wide range of when those membranes actually resorb. Some of them as soon as 6 weeks, some of them as long as 38 weeks. And so then the question becomes, how the heck do we know which one is a quicker or longer resorbing? And that really comes down to whether or not those membranes, when you look under a microscope and see their substructure, whether or not they are cross-linked or not cross-linked. So, like I said, I don't want to overwhelm you with info. The point being that when it comes to talking about regeneration, the different bone graft options that you have, and the different membrane options you have, this is a far more involved type of conversation, but these are all part of your overall kind of portfolio and thought process when you enter your case. And again, going back to tip number one in terms of planning ahead, the more information you have, the more you can start thinking about which one of these materials you're going to be using, the better your outcomes are going to be. Now, we talked about these extraction cases. I just mentioned these bone and membranes, and these are all going to be for situations that are going to be when bony defects are present. So the take home for everybody is if you extract a tooth, you have a fenestration or a dehiscence, you always want to utilize a bone graft and a membrane. But then comes the question of, as we mentioned in our opening slide, what if there are no bony wall defects? Well, in those situations where you have nice 360-degree solid bone, you have another option available to you. Now, to not confuse anybody, the literature is very clear. At the end of the day, using a bone graft and a membrane together is always going to yield you the best overall result. But if you have a very wide ridge and you have all of your bony walls intact, you can also employ the option of using your bone graft material, but utilizing on top something known as a collagen plug. So collagen plug, or another version of it, which is in the form of a longer strand known as a collagen tape, is also another very effective option when we have all of our bony walls intact, because what these plugs are going to help us do is it's going to help us wick that bone and get very good clotting for those first 2 weeks of that extraction socket healing. So it will provide protection over the socket and the graft that we have put. It will help with our overall clotting, and of course, it will resorb all on its own. In fact, these materials have become so popular that what you're going to find right now on the market, and something that our friends tonight that are sponsoring in ACE Southern have excelled in, is this concept where they realize, well, what if we put both of these things together? Plugs are so popular and so useful. We also know that we want to have bone grafts within these sockets because we need the bone grafts to help have better regeneration. So what if we combine the best of both worlds? And so what you find on the market now from some of these companies is a combination of a collagen plug that actually has xenograft bone particles within it. So again, in your nice intact sockets without your bony wall defects, these can be an extremely effective type of material. Now, there are multiple different companies that have different versions of this on the market. I show you three examples here. We highlight our friends from A Southern with their product known as Nuos. And as you can see, what's unique about them is that they have plugs that are also tapered, which depending on which route you're working in and if there's any curvature, will help you get those into those sockets a lot easier. I want to show you a couple quick examples of each. Here's a very quick just play-by-play video of an extraction socket. This first one is using that Biogen plug that I showed you. This product is more synthetic. It has less of that xenograft crystal that's there. So I personally, of all of the options that are there, don't think it's the best one of all of them there, but it is an example that can be used. But what you'll find is here is another extraction case. We've sectioned our tooth. We've removed that tooth completely atraumatically. We've recognized and tested and seen that we have no bony wall defects. So again, here's a indication where this is a tooth that is being planned for, whether you're doing an implant or a bridge, but we're getting this combination of a plug and xenograft in one. We're able to fill our sockets, and what you'll find radiographically, you can see that nice solid bone that is able to heal in there and regenerate within that socket. And this, the most recent, this was just last week in the practice. Again, our friends from Ace Southern with their Nuos plug, same concept, tooth extracted. There's our combination of our plug and our bone graft in one. You can see the way that fills the area in. And then immediately post-op, we can take our radiograph, which I think on the computer might be a little blurry for you guys, but the long story short, we already see our socket is completely filled with that graft material. We're still going to be waiting those multiple months of time to allow the maturation process to occur, but this just provides us more flexibility in terms of additional options. So more options that are there for you. Again, I really would only look at these types of products in cases where you're either going to be restoring with a bridge and or you're going to provide extensive healing time with no bony wall defects. Otherwise, again, the traditional bone graft with a membrane is still our gold standard way to go. So that gives us another option there. Again, we mentioned there's a lot of lingo with regenerative materials. Same thing with flap management. We don't have in tonight's course an opportunity to go over all the tips and tricks about how to lay flaps, about how to create vertical releasing incisions. But the take home for everybody is anytime you extract a tooth, if you've identified a fenestration or a dehiscence, you have to be able to access the base of it, and you have to be able to access a several millimeters beyond the apex of where that defect is in order to, number one, be able to clean out all the infection that's there. But number two, to then be able to make sure that your graft and membrane material are able to cover the entire length of that defect and not only a part of it. So flap management is something that is going to be key for doing these procedures as well, and another important part of your overall success. So the point I make to everybody is if you are ever in doubt about whether or not you might or might not have a defect, when in doubt, always raise a flap, because that is going to be the best ability for you to get complete visualization of the defect and ensure what's going on. Ultimately, you're going to be better off knowing that than trying to be quote unquote conservative, a word within perio I do not like, and be able to ultimately miss out on a potential defect or more infection in the apical area because you weren't able to visualize things enough. So very, very important about flap management. And of course, depending on the type of flap that you've done, it comes down to suturing and what type of suturing material you're going to use. Again, we don't have time to do a full surgical in-depth on that, but I wanted to give you two takeaway materials to take with you today. Everybody's heard of chromic gut, of course. Chromic gut is not a very friendly material to use. It wicks blood easily. It sticks all over your patient. You see it get wrapped around their chin and ear and nose and everywhere. But two very high-end, high-quality, and absorbable resorbing sutures that we'll find on the market. Our friends at Osteogenics make one known as PGA Resorba, which is very similar to like a Vicryl, and another material known as Glycolon. These materials are extremely tissue friendly. They have very good tensile strength, which means when you tie them off, they're going to be able to keep their rigidity there for the overall healing process. You are, of course, going to have to bring your patient back in a couple of weeks, not only to check on them, hopefully, but to remove those sutures as well. But unlike a chromic gut, which usually by around 1 week's time is going to be resorbed away, if you have a more involved and bigger infection site that you are healing, or let's say you have multiple teeth side by side that you're extracting and you want to make sure that you have much better closure for a longer period of time, these two materials will hold and have very good tensile strength and give you really good results. So I wanted to show you guys two quick examples of those. So we talked about this whole step-by-step methodical system in terms of sectioning, using our instruments, using our traditional elevator and forceps. We just want to show you a quick example to put these things all together. So here's a tooth that, of course, has been broken down to the osseous crest. We don't have much tooth structure to grab onto. We're going to go with step number one to section this tooth. We have our electric handpiece. Because this is natural tooth structure, we're using a surgical length carbide, which in this case is a 557. We're dividing this molar into its mesial and its distal roots. So that is going to be our sectioning that's going to occur. We're then going to come with our targeted exotomes. Like we mentioned, we put our periotome in. We come in with our exotomes. Again, we use these as we would a traditional elevator, but we use them on both. In this case, this exotome is targeted specifically for that mesial root. You can see I've already been able to do the majority of the luxating there. The same thing on that distal root. Different exotome has a different angle. Again, the exact opposite of what we did on the mesials with our distal. And as you can see, as a result of using this exotome, we are able to create so much movement and mobility on this root that it's not putting any pressure on the buccal plate. And this was the video you saw earlier where, again, 90%, 95% of the work is done. So now, by the time I grab this with my forceps, I just employ a very light amount of rotational movement, and that root just is able to pop out for us. So that's the goal of doing these things in a very systematic step-by-step process. Of course, then we have the critical part of doing our curetting that we mentioned. Here's the instrument, and it will be on your free surgical instrument list, but from our friends at PDT, known as a Slade blade. You can see the way we put that gauze pressure in there, leave it, and then we go through the process of spending an extended amount of time making sure that there's no infection left within our socket, which I guarantee you there always will. After we curette, we put our gauze right back in, and we do this same trick back and forth as many times as we need until we make sure that there is no infection left. And then, of course, we can go through our regeneration process of putting in our bone, our membrane, or our plug, etc. And after we've packed in our bone in that area, we have the situation where we have a nice intact socket. We have the area covered, and we put our sutures there to keep nice pressure on that spot. So our goal at the end of the day is to approach all these cases the exact same way. That prepares us from an instrumentation standpoint, from a procedural standpoint, and even if we get in situations where we have undercuts, very brittle roots, and we may even have to do a small amount of troughing, no big deal. It doesn't change our order. It just means after we do it, we go back to our exotomes again, and we go back and forth until we remove these teeth. So we've understood in tip number one what we can do to prepare in advance. We now know to be prepared with the biology, set the expectations, to have an idea of what our materials are going to be as well. We now have our step-by-step in terms of knowing how we're going to approach each of these cases. And our last step is really about understanding that we want to build on this with time. And the key to all of this is repetition and with mentorship. We're all capable and we all know how to extract teeth, but it's no different than anything else we do. The only way that we can become super confident and master these techniques is not only by doing them often, but by being able to receive feedback and mentorship. And if we can have a mentor and a community of our colleagues that are doing these cases, and we can bounce off our cases and experiences and ideas, the better that we're going to be able to do. And what happens far too often in our profession, we're just expected to learn things on our own. You've taken an extraction course once, great. Now you can know how to take out teeth for the rest of your career. You've done dental school, great. Now you know how to run a business. And as we know, that's simply not reality. So whether it's learning how to ride a bike, learning a language, or drive in stick shift, as we all know, doing it one time or taking a course once is simply not enough. We need repetition. We need to be held accountable. We need to have a community of our peers to be able to share these cases and ideas and get feedback and learn our lessons from. So in order to do that, we really want to offer an opportunity for everybody here to be able to be a part of a type of community like this, where we can educate these topics in a lot more depth and detail, but then allow you the opportunity to share your cases, to get feedback on the experience experiences that you're having, and to be able to have access to these lessons on a modular online setting so you're able to constantly get more and more repetition until the point that you feel extremely confident to basically be doing these cases with your eyes closed. As all the studies have found in corporate America, when we employ this type of mentorship and community type learning, the result is that we simply have more confidence and are able to do our job better, which ultimately leads to a greater amount of production for us, which is what we want as clinicians, and better outcomes for our patients, which is, of course, what our patients want at the end of the day. So, as great as it is to come to these types of courses and learn hands-on how to do these techniques, if after that course you're not able to have that feedback moving forward, it's going to be very difficult to retain all of those tips and tricks and information moving forward. And that's why we want to allow that type of community environment. So, how are we going to do that? Well, we're going to show you right now in our conclusions, but to tie things off with a bow, we wanted to mention in our very brief time that as we've learned, in order to have success in getting these surgical extraction cases done, it's all about knowing what you're doing before you've ever touched the patient. Leverage the 3D imaging, have a good idea of the biology, understand the different materials and the options that you have, and be prepared from the very beginning. Again, everything for your atraumatic success is going to be dependent on your instrumentation and your technique. You now have a step-by-step process that you can rinse and repeat for all of your cases, no matter what tooth and where in the mouth and what that situation is. It's all about divide and conquer. Again, things like regenerative materials, flap design, suture technique, understand that all of these steps, each and every one of them, plays a significant role and has an impact on your overall outcome. So once you get very comfortable on how you're going to be sectioning and removing these teeth, employ the same type of education to learn all about these regenerative materials, the flap design, and your suturing as well, so you can continue to get better. And as we've now seen from groups like our sponsor here at A Southern, we have these new products that combine two in one that gives us greater flexibility for overall results. So, in the spirit of trying to learn these things in much more depth over time, as promised, I've provided everybody with a free surgical instrument list. You can just scan this barcode there. So from everything from curettes to bone graft materials, membranes, implants, implant motors, you name it. I'm providing this because everybody always asks, what are some of the tips and tools that you like to use most? So everybody has free access to this. So I'm happy to share that with all of you. In addition, for those of you who want to continue your journey in mastering these surgical techniques, want to start mastering things like the regeneration, the regenerative materials, some of those flap techniques and suturing, you're more than welcome as you continue to improve and just become better in your journey to join our community for learning this surgical confidence. We have an online community where in our site known as masterclinicalsurgery.com, where you can sign up for this surgical extraction and grafting accelerator. We do live sessions, we do live hands-on as well. So we'll be able to take this lesson and raise it to that much more depth and detail moving forward. So I invite all of you to feel free to reach out on the site to get more information, or the easiest way of all, feel free to follow me. That's my social media Instagram handle account there with that barcode there. I hope each and every one of you can follow so that we can remain in touch and keep you updated for future courses and things that are going on. I'm always keeping very active and helping all of our colleagues in the field. As you can see, I've written a book to help us for starting our dental careers with finance, hearing protection, a lot of different things. So ultimately, I'm here to try and help each and every one of you. And I hope in our very brief amount of time, everybody has a few tips and tricks that they can move forward with them as they move forward with their extraction. So with that being said, I am exactly at an hour as promised. I won't hold you any longer. I'll stick around to answer any and all questions that you might have. And again, thank you all for sticking around tonight on your evening, and I wish all of you the very best.
Great. Thank you for that wonderful presentation. We do have a few questions. So if you don't mind me asking,
Sure.
I'll start from the top. One instructor advised to cut off clinical crown, leaving roots to be removed. Your comments?
Totally fine. Again, depending on the situation, some of those clinical crowns have so much decay, or they're so brittle from endo that, you will at first think, well, let me keep more tooth structure and keep the clinical crown there. But then as soon as you start trying to work on an elevate it, it breaks off anyways, and you're left with nothing but the root. So, in those cases, you can cut to the chase. Well, excuse the pun, and just go straight to the root. But I do think if you have a clinical crown that is a little bit sturdier and can be used, sometimes I think it's better to have it there because after I do my periotome and I exotome work, if it comes to the point where I do want to grab it with a forceps, I just feel like I have that much more tooth structure to grab onto as I'm doing my rotational movement. So if that root is sticking up enough where you can grab it well anyways, great. But if it's something that's broken right down to the osseous crest, sometimes that option's not there. So I would rather have the extra tooth structure there in that situation. But again, totally depends on whether or not there's significant decay or not. So that can really vary.
Another question is it the same billing code for the plug?
Yeah, that's a great question. You would, and the reason that you would end up doing that in the case of that kind of dual type of material is because technically, again, that dual material does have that xenograft within it. So you still end up having, both things there. So you would still code it the exact same, even if you're doing it that way.
How do you section a single root tooth?
Yeah, great question. So it sounds a little counterintuitive because it makes sense multi-rooted. Okay, divided into its individual. But what are you going to do with, for example, a premolar that's single-rooted or a canine that I mentioned? So what you're going to be doing when those single-rooted teeth is you're actually going to go horizontally right across the midline of the tooth. So instead of going in more of a buccal lingual direction, you're going to be going in a mesial distal direction. So the reason that you're doing that is once you do that, all of your pressure and force that you're going to be doing with your exotome is going to be going towards that midline that you've sectioned. So again, the goal is that you're pushing everything towards the middle where you've created an opening as opposed to towards that buccal plate. And again, what you're going to find is with canines that have really prominent roots, or even if, again, imagine a central incisor, aesthetic area, razor thin buccal bone. For those of you who are thinking of doing implants, much less immediate implants, and it's a severely decayed tooth that had a post that broke and is endo treated. How the heck are we going to get that out without, damaging things? So in that area, I will do that same type of sectioning and I will put all of that force towards that middle section that's there. And I'm going to be getting essentially two small pieces out doing it that way. Because again, if it is severely decayed like that, my ability to go and have something to grab onto, it's simply not going to be possible. So that's what I'm doing with those single rooted teeth.
Do you rinse with saline or Paradex before grafting?
So definitely rinse. There's a couple products, and I think I have it on the surgical list there. If I have a very infected socket, after I do all of my curetting, I actually use a gel known as Hybenex. It's from a company known as Epian Medical. This gel I will put into that socket for about 30 seconds before I rinse it out. And it is an atom bomb for biofilm and bacteria. It's going to completely kill everything off. So, and it doesn't harm tooth structure, bone, soft tissue, or anything else. So just know you're cleaning bad bacteria, but you're not damaging healthy structure. So I will always do that. By all means, you can definitely, before you do that, or even after, you can rinse with saline as well. Paradex, I don't use as much. Again, it's been kind of lost favor. It's starting to show damage long term on fibroblasts. So if I'm ever going to be using any type of a rinse in a patient's mouth, there's a rinse known as Closis. It's an over-the-counter rinse that is extremely effective, very antibacterial, doesn't stain, doesn't itch or burn or anything like that. So that would be my go-to in that case.
I've been using Encore 70 over 70 by 30. Do you see significant better results with Encore 50/50?
Yeah, great question. I don't think you're going to see some massive clinical difference. If you want to do histology and start looking at it, is there going to be maybe a small difference between them? Yeah, maybe, but is it going to be something that you're going to see a massive difference? No, not really. Again, I put that 50/50 example up because it is, again, a very balanced, literally amount of each. And again, as far as just trying to give an example of one good bone graft that could really be used universally in all cases, that's just kind of a good go-to. Again, keep in mind if this is a situation that I'm planning on an extensive regeneration that I'm going to be waiting 6 months. A lot of times I'm adding xenograft as part of the procedure because xenograft sticks around for a much longer period of time. So again, this starts getting into a little bit more of the nuance of stuff. So again, that 50/50 is kind of a really good balanced way of doing everything. But if you're using that 70/30, that's great as well. If we were to go with a microscope and look in there, you're not going to see some, significantly drastic difference between there. So I wouldn't stress about that too much.
How do you get access for for all those hands-on courses?
Well, the best way to reach out again, either via social media on that QR code I had, or you can go onto the site masterclinicalsurgery.com and get info there, and we can direct you one way or the other, and of course through Catapult as well. We have a lot of great courses similarly as well that will be promoting moving forward. So couple different areas to go, but if there's any specific course questions or info, a lot of times the easiest thing is to just reach out on social media or on the website, and that way you can get in touch directly.
Real value in such high-level overview. Excellent presentation and resources in the changing discipline. Thank you for a great lecture, Dr. Shamardi. And another question was, I currently have an aseptical portable surgical handpiece motor. I was wondering what settings you recommend for ratio, RPM, torque.
Good question. I'm not as familiar with the Aseptico system. The one I have is on NSK. That's their electric. That's the one I have. I put their setting at the highest possible. I think it's, what is it, 200,000 RPM. The key is if you're using the electric, its torque value is essentially, preset. In other words, if I'm using my Z95L, which is my NSK electric, that torque value I think is in around 42 or 43. So what's great about the electric is that I'm going to be getting that consistent amount of torque the entire time I'm sectioning that tooth. Again, what differentiates that from an air driven is that when you use an air driven handpiece, uh, regardless of what speed and RPMs you have it set at, the moment it starts to hit tooth structure, because of friction, 40% of that speed is going to be lost. And so that's what makes the electric such a big difference because it's not dependent on the speed. It has that consistent level of torque that it's going to be using the whole time. And so I think that's really why, from a extraction standpoint, again, crown preps and restorations, totally different story. But when you're talking about these extractions and cutting through those type of material, the electric really is a game changer for that.